Good afternoon, everyone. So my name is Janet Hankins. I did my practicum here in the School of Public Health and Social Policy. Today I'll be talking to you about implementation science frameworks for a research proposal for the HIV pre-exposure prophylaxis or PrEP scale-up in BC. So just very briefly, I'll talk a bit about what implementation science is, a bit about the intervention, then about frameworks and framework selection and the public health potential of using one. So implementation science is the study of what interventions work within the health system and why, how these interventions can be implemented, adapted to other settings, or scaled up across regions to improve the quality and effectiveness of population health, health services, and care. In this case, the disproportionate HIV burden on men who have sex with men has prompted implementation of PrEP as an intervention in BC. Using an implementation science approach to plan, execute, monitor, and optimize PrEP scale-up across BC promises to reduce HIV incidence while gathering knowledge applicable to future interventions. So, the purpose of this is really about risk mitigation, because whenever we do an intervention, there's a risk that we will have unintended consequences or little to no impact and be wasting resources. So we mitigate this through the use of established formulas or frameworks, proven implementation strategies, and accessing a cumulative evidence basis by population intervention setting and scale. PrEP is an innovative HIV prevention strategy that's been available in Canada since 2016 and publicly funded in BC since January 2018. It's the daily use of antiretroviral therapy, or ART, by HIV-negative individuals, and it's proven to be highly effective protection against acquiring HIV in case of exposure. Together with regular HIV testing and effective ART treatment of individuals who are already living with HIV, PrEP has the potential to reduce or even eliminate HIV transmission in BC. For this reason, PrEP as an intervention is aimed at individuals with a high risk of exposure to HIV. So, and the individual route to accessing PrEPs begins with a patient perceiving their own sexual health risk. And upon seeking perhaps STI testing or PrEP itself, a clinical assessment for PrEP eligibility is done, and this involves both lab tests and a behavioral risk assessment. If the person is eligible, an initial 30-day enrollment form is completed and submitted to the BC Centre for Excellence in HIV, and a 30-day prescription of PrEP medication is dispensed. By the end of 30 days, the individual presents for a reassessment of their eligibility, and if they're eligible, a continued 90-day enrollment form is completed and submitted, which then releases a 90-day prescription. And at this point, the person then continues in this 90-day cycle of eligibility reassessment. So I'm going to skip that one for the sake of time. You can ask me about it later if you want. So the main stakeholder providers in PrEP, first of all, the BC Centre for Excellence in HIV or AIDS, or the Centre, provides the clinical guidelines as well as clinical education, training, and support for HIV prevention and treatment in BC. Then we have the regional health authorities who coordinate service delivery in their area. Very key, we have the primary caregivers who are being asked to adopt these new protocols into their practice. Then the community health organizations who provide a credible link between healthcare providers and the target populations, as well as advocating for those target populations in the standard of practice. Lastly, the BC Centre for Disease Control is responsible for surveillance of reportable diseases, which includes HIV, along with public health outreach, sexual health clinics, and audit and feedback to the health authorities. And together, this is the community of practice for PrEP delivery. Now, switching gears, implementation science framework, applying an implementation science framework to this, this is really conceptual architecture that's used to guide and support implementation of an intervention. And this systemization really increases the rigor of the process and by extension, the chances of its success. There are many of these frameworks available in the literature, and that makes the selection process really overwhelming for a novice such as myself. So I began my practicum with a scoping review, and we'll just move through this quickly. What I can tell you is what I learned from the 14 empirical studies I shortlisted was that there was no obvious choice. However, the systematic reviews and guidance documents were really helpful in providing me with some selection criteria. There were 19 selection criteria listed in the reviews that I read. I found these 7 to be the most applicable. So firstly, objectives. We want to analyze what's already being done in this program, and then also have the capacity for incorporating scale-up information. As I showed you, this is a pretty complex intervention requiring systems-level capacity, and stakeholder engagement is key, both on the patient side and the provider side. Many of these frameworks really focus on providers. Ease of use was important. It needed to have good resources and be well tested, and it needed to be evidence-based, preferably with systematic reviews by people who weren't the framework author. And lastly, I never stopped searching for comparable studies, and I found one eventually. So the first framework chosen is a determinant framework, and this was really going to allow us to inventory the current intervention. The Consolidated Framework for Implementation Science Research, or CFIR, has 5 domains and 38 constructs that examine first the characteristics of the intervention, secondly, the outer setting, and this houses both patient needs and the policy environment, then the organizational factors of the actual care setting, the characteristics of the individual service providers, specifically their competency, confidence, and engagement in providing the intervention, and the process. So what resources are available for ongoing sustainment of the intervention. This was fantastic for taking an inventory, not necessarily for providing an evaluation of how things are going. So a second framework was sourced. This is the REAIM framework. Also has 5 domains because 5 domains is very popular in this game, I can tell you. So what was great was the very first one was about reach. And this is the number of your target population who have access and are willing to use your intervention. Effectiveness. Is it achieving the public health outcomes that you care about? Adoption. Is it being brought into practice by the care providers? The intervention itself, how closely the guidelines are being followed. And lastly, is it sustainable? Is it becoming a routine part of care? So the part that we all care about, public health potential. So it comes at 2 levels in something like this. The first level is project specific. PrEP scale up across these different regions, across these different cultures, has an improved chance of success with good audit and feedback mechanisms and the testing of different strategies for that. More broadly, it informs better planning going forward for this level of intervention with this population. And in the larger picture, it contributes to a library of tools with evidence bases by setting population and topic. So one thing I'm just going to throw in here, even though I know I've got like 1 second left, is that one of the things that was most fascinating to me in this project is we're talking, most of the populations affected by HIV also suffer from syndemics. And syndemics is something that I read a lot about sort of in its initial stages in the literature, but for which I never really found frameworks that were specific to. So I think that that's a very interesting aspect of this project. So hopefully it gets funded and there'll be an MPH student working on it next year. So many thanks. I had 2 fantastic supervisors, Dr. Nathan Lachowski and Dr. Kiffer Card. The entire implementation project planning team was fantastic in their support. Carol Gordon was a great mentor for coming in off the bat, so I want to thank them all for their support and guidance.
Thank you so much. Any questions? It's all right.
Just make him run back and forth.
Backwards and forwards. I want to work that pizza off, so that's good.
Hello, that was awesome. Thank you. You may have said it, but I'm not remembering. Can you explain what scale up means?
Oh, absolutely. So scale up is essentially when you're trying to move an intervention outside of a particular geographical area, especially into other regions. So theoretically, from the start, people living in Fort St. James or Campbell River could have accessed the PrEP program, but really the most activity was centered around the Lower Mainland and perhaps Victoria, and that's because that's where the major centers involved in doing this are. So this is really about pushing it out and getting it integrated more broadly into all of the health authorities in BC.
Thanks, Janet. That was great. And you did some really lovely work, I have to say. Distilling down all of those frameworks into something that's comprehensible is quite an achievement.
There was 112.
And counting.
Are you making a new one? Is that what you're telling us?
Yeah. And I guess that's my question, is really just any thoughts you have. So implementation science is the flavor of the year, or maybe the flavor of the decade. We're all doing implementation science now. I think we might have used slightly different languaging around it a decade ago and be doing kind of the same thing. I guess
jargon was a big thing in the search.
Jargon is a big thing, yeah. And I guess just when you were looking through the different models, typically the way these types of sort of pragmatic, function-oriented kind of models are framed is around this idea that there's this gulf between this pure evidence-based intervention that's been developed and then what actually happens, right? What other factors do you think are at play underneath? Why all of a sudden this explosion of implementation science models, in addition to that?
Well, I think what it comes down to, and I can't remember where this quote is from, but what gets measured gets done. So I think part of it when we're trying to address these health inequities is just having the numbers to show what's working and that it's worth doing. So I think that that's a big part of the drive. I mean, knowledge translation in general, I think it's been done for a lot of years, and now all of a sudden people are recognizing it as a very distinct entity that could receive special funding. And anything that receives funding where you're not competing with everybody is always a fantastic thing. A lot of the evidence around PrEP, because PrEP has been in place in the United States, in Britain, in Australia for some time. So a lot of the evidence basis for it is not necessarily the same kind of strict clinical trials as you might have with a more captured population. But one thing that I did find very interesting was there are starting to emerge, and I would have loved to ask Charlotte more about the Indigenous framework she was referring to. There is more stuff starting to emerge around different frameworks for different populations, because I do think that there are some interesting questions to be asked around dealing with populations that do suffer from or from the whole concept of syndemics and really addressing things more holistically.
Good. Thank you
Thank
very
you.
much. Excellent.